It gives me pleasure to invite the next speaker, Dr. TANVI HALDIPURKAR Venkatramani. She is a cataract refractive consultant at Lakshmi. And today she is going to speak on the role of dry eye in cataract surgery. TANVI.
Thank you. Good afternoon, everyone. A topic as dry as the name suggests. I am hoping to infuse some juice into it and change our perspective and bring it to our clinics and how we can approach dry eye. So let's begin. As you will see further in the talk, dry eye is complex and it is a subjective diagnosis because there are several definitions to its names. A good place always is to start with the TFOS, that is the Tear Film Ocular Society classification, which tells us that dry eye is a multifactorial disease. It has a lot of problems, ultimately leading to a tear film instability, which is caused by which lands up with a hyperosmolar tear film, and finally ocular surface damage. Dry eye really is a conundrum because the pathology of the disease is still evolving. A lot is being studied about it and about tears and how they affect the ocular surface. But what we know is that a huge proportion of the population suffers from it. But a fraction of it is diagnosed and a small number is actually treated. Over the years, we know that it is not just the older population which is affected, but many young patients are now suffering it. And these are our prospective cataract and refractive patients. And if we misdiagnose them, our surgery will put them in a vicious cycle, causing tear instability and finally surface damage. This is an electron microscope image of the epithelium, and it is obviously not smooth. What makes it smooth is the tear film, and we don't truly appreciate the job that it does, and mostly we take it for granted. But we now know that a poor tear film will cause issues right from a poor optical visual quality. There will be problems in data measurements and then surface damage. I recently came across this hypothesis which helps us to categorize dry eye better. The tear film stability is equal to the tear volume, which is in turn determined by the tear production by the lacrimal glands and the evaporation that occurs and the outflow from the lacrimal apparatus multiplied by the corneal wettability. Now, this corneal wettability is dependent on the optimal functioning of the mucin hydrogel layer in the tear film, and that's something worth looking at in the future. So dry eye will then either be a dry eye because of aqueous deficiency or evaporative or mucin deficiency, which is causing the decreased wettability. So before it gets too dry, let's look at a patient who presented to us for cataract opinion. This is a 60-year-old female having minimal symptoms of dry eye, was on lubricants on and off, but had reduced quality of vision. Now, to be honest, in a busy OPD, sometimes we don't begin with tests of dry eye and jump directly into a biometry to plan for the cataract. This case is a great example of what can happen if we do that. So she underwent a lens star measurement as well as a Varion scan. It is always a good idea to look at multiple data points from different machines, because that's going to give you a clue for your astigmatism. Now here you can see the keratometry values from the two machines are not too different. It's a good idea to look at the raw data. There you can see the lens star raw reflections are seen because this validates your data. And you can see that the reflections are not precise. Some are darker than the others. Her keratometry on the topography was irregular and prominent on the tangential map. But surprisingly, the amount of astigmatism for her left eye was recorded as 0.2 versus the 2 diopters which was recorded with the other instruments. So a good clue for dry eye or tear film instability comes from with the same eye data when measured by 2 or more machines. Interestingly, we had a scan of this patient from 2 years back, and the cylinder in her left eye had increased from 0.5 to 2.5. Now, this change can only be explained by some change in the ocular surface from which the data is recorded. Obviously, her length of the eye hasn't changed. Although her symptoms were minimal, she had several clinical signs suggesting of a mixed type of dry eye with definite ocular surface damage. An ocular surface analyzer scan then helps to educate the patient about the tear film status. You can see here that the lipid layer on the ossa was absent. We did have an access to an epithelial profile, and since tear instability ultimately leads to surface damage, we scanned her epithelium. And to both our dismay, this was her epithelium. It is thin, irregular, worse in the left eye, which rightfully showed the eccentric data measurements. And if the patient or even you are still not convinced, let's look at the eye tracy aberrations coming from the eye. The left eye in particular shows a reduced DLI, which was because of a cataract, but also a poor corneal visual quality, which was adding to the total visual blur. So just a cataract surgery was not going to solve her problems, but may even exaggerate them. So this cascade of scans began because we had a high index of suspicion when two machines gave slightly different values. We could have neglected those red flags, and then what could have happened is we would have used a wrong intraocular lens power, which would then have landed in a refractive surprise. You can see there's almost a 2 diopter difference. So changes in the tear osmolarity have shown to change the keratometry readings and to give inconsistent measurements. You can see here that there's a scatter of eyes which are more hyperosmolar as compared to the normal, and variability of up to 2.5 diopters is seen in some eyes. So that is the impact of the poor ocular surface on our cataract patients. You know that the dry eye affects the normal functioning unit, the affector and the effector arms, and what happens is it ultimately leads to an upregulation of cytokines and inflammatory mediators, which disrupts this cycle, leading to a surface damage. So our goal ultimately is to rescue this eye from this vicious cycle, and which is causing the damage, and to improve the tear film stability and to maintain the homeostasis. So the question to ask is, what can we do? To be a little philosophical, I can say, seek and you shall find. Dry eye or tear instability is almost always there until proven otherwise. Our lifestyles have changed since the lockdown. There is definitely an increase in the use of screens and the use of masks. Both have exaggerated the dry eye issue. This was a recent study done by Trattler, which showed that almost 76% of patients who presented for cataract surgery had positive corneal staining, and a big number of them had a tear breakup time less than 5 seconds. Now, that's a significant proportion of patients having dry eye. So a good approach to our routine practice would be to recognize it preoperatively and to take measures during and after surgery to keep the damage to the minimum. So tests for dry eye are many. We have added ocular surface analyzer and the ASOCT in our practice, as it helps us in managing them better. But certain dry eye clinics who specifically look at the tear status may also test for osmolarity, biomarkers, and corneal nerve testing. Now, this does give valuable data, but in practical use, they are really difficult to conduct and are kind of impractical in the current scenario. A good history, simply asking for medications that can reduce the tear secretions or increase the dry eye, like the antidepressants, anticholinergics, or even a history of smoking should be asked for. And of course, a good standard clinical examination can reveal a lot. There are several algorithms available today to avoid missing the diagnosis. This one is from Tear Film Ocular Society, or you can use the one given by ASCRS in this article. So once you've diagnosed it, it is very important to then educate the patient. A little increased chair time before surgery will help resolve this issue, because I'm sure that after surgery, if there is dry eye, they're going to associate it with your surgery. Now, reports like the OSA help to show the patient the layer which is deficient, and it helps us to target the therapy accordingly. And once a surgery is planned, we can then start a preservative-free lubricants, and in some cases of severe dry eye, even cyclosporin 2 weeks before to regularize the ocular surface. And use of preservative-free medication helps us to keep the homeostasis. And of course, we treat the dry eye if diagnosed. What do? We follow roughly the DEWS 2 protocol. We can use antibiotics, warm compress, secretagogues, or even intense pulse light therapy, depending on what type of dry eye the patient has presented with. During the time of surgery, using intracameral anesthetic and dilating medications can further help reduce the ocular damage, as repeated drops that are kept on putting before surgery can cause conjunctival cell damage. We can also reduce the light from the microscope while operating, or switch it off during instrument changes. Use of 2% HPMC has been shown to, to coat the cornea, has shown some protective effect. And when opting for LRI or any corneal incisions for astigmatism, we might counsel the patient preoperatively and treat the eye for a longer time with lubricants postoperatively. And of course, longer surgical times causes more drying and damage, and we should know this and be aware. Dry eye patients can be kept on lubricants for a longer time depending on their symptoms. There is definitely a role of these molecules, the cyclosporin, diacoazole, rebamipide, and sodium hyaluronate. So some of them are not in use in India as of now, but I'm sure that this will come soon in the future. And use of masks or sitting in front of the air condition can be counseled to the patient post-op because they may not face these problems before surgery, but this becomes exaggerated post. The last case that I want to show is of my refractive patient. He had come for contoura LASIK and had moderate myopia with low Schirmers and no symptoms for dry eye, except that his vision in the right eye was suboptimal as compared to the right. His clinical examination revealed signs of ocular surface damage, and the OSA showed a mixed type of dry eye. The ASOCT showed central epithelial thickening in the 5 mm zone, which was more in his right than his left. His topography on the first visit was fairly all right, but it did show some skewing. His topolizer scans were variable owing to the tear film instability. And he was advised dry eye treatment for 3 months. Now you can see the one on top is his the first scan, and the one lower down is the scan after 3 months. This was after 3 months of dry eye therapy. You can see that the bow tie has slightly regularized, and there was definitely a small change in the cylinder on topography. And this is his epithelial scan after 3 months, which was much more regular, and there was definitely less thickening of the epithelium. Now, at this point, a decision can be taken to undergo LASIK or not, and this will give us a more predictable outcome. Now, the change in his epithelium also reflected in his refraction when he accepted a cylinder of almost 1.5 and had a sharp 6/6 vision, which he didn't have before. So to conclude, I would say, seek and you shall find. Dry eye is almost always there. It is important to follow a strict protocol for every patient so you don't miss the diagnosis, and measure with more than one machine. This always gives a clue about the ocular surface. Stabilizing the ocular surface is of utmost importance in surgeries where the data is collected from the surface, like contoura LASIK, even for your topography, even for the toric lens evaluations, because it will give us better results and disasters otherwise. Don't take the surface for granted. A good surface preoperatively does not mean a good surface postoperatively, which is why we need to counsel the patient. This is a list of preservative-free drops which I thought might be useful. And with that, I want to thank our audience and the panel for your patient listening. Thank you.
Thank you, Tanvi. It's a good talk, but then have you in your practice noticed that in spite of all this, the incidence of dry eye in the patients after cataract surgery, have you been seeing often?
So if there wasn't before, it was probably not diagnosed by us, is what I believe now, because dry eye in the current scenario is always there. Maybe they just didn't have the symptoms for it. Post-operatively, if I feel somehow that our patients or the type of patients that we see are quite less demanding in the sense that they don't really complain much. But I'm sure that if we go and check their tear breakup time 1 month after cataract, even 1 week after cataract surgery, it would be affected. It's just that they don't feel those symptoms anymore. But a good idea would be that the minute they say that I'm having a little bit of gritty feeling or a little bit of foreign body sensation, to go and maybe do a good dry eye workup and then start on these medications. So the quality will also improve for their vision.
Maybe sometimes if you kind of give them an idea.
Yeah,
that,
so counseling, I think, is
I'm
the
sure
way to
the
go.
audience would also have the same experience that compared to practice in the earlier days, now post-op patients coming with complaints of dry eye are suddenly more than in the past. Has it been your experience, the audience? Anybody wants to share something? Yeah.
Hello. Well, partly I would tend to agree with her that probably the dry eye was there pre-operatively also, but it was never diagnosed and it only got exaggerated post-op. Now my one question is that in light of all this, can we ask the pharma industry to make most of our topical preparations in HPMC? Would that be of help? Because I think the toxicity due to topical use of eye drops continuously for 2 months post-operatively also is a contributing factor to the enhanced cases of dry eye. So can we ask them to make most of these formulations in HPMC? Would that be of help?
So I think that that's one point to be noted, because most of our drops do have preservatives, and they kind of do need to. That's probably the future. But obviously, the the cons of having a preservative-free drop in a society where, or in a place where the patients cannot handle them very well, might be the reason why they're not doing it so. But if we know about it, then we may, there are certain options like I showed you in the last slide. They are available and in all types of molecules, so the steroids, the antibiotics, the lubricants. So if we know about the dry eye situation, we can then shift for those patients to those molecules. So that could be for now.
I get your point. Maybe it's worth, exploring this possibility of having most of the drops with HbA1c to soothe the effect. Yes.
So I just like to share personal experience. I'm Dr. Kumar. I'm at Hinduja Hospital. Before this, I was at Moorfields. And my mother had a cataract surgery, 6/6 vision post-operatively, really bad dry eye. And I most probably was the most incompetent son she had for 6 months. So to the extent where she saw 4 people out here, ultimately I got fed up and I said, your surgery's gone very well. I sent her to Moorfields. I got her to see a lot of people there as well, David Gartry, and everyone saw her and they said, oh, it's only dry eye. And what I'd like to emphasize to the audience is what you brought up is very nice. For us, it's only dry eye. For the patient, it is worse than having the cataract surgery done. For 6 months, I was hearing this drop is not working. I tried all the preservative-free drops there are in India. Then I got them from the US, then I got them from UK. Then something called Hyalonite, which is just sterilized paraffin. Worked wonders when she put it in at night. But these people get really symptomatic and we tend to dismiss them. Till it happened to my mother, I had patients like that who would say, it's a bit itchy, and I'd say, you idiot, you have 6/6 vision, you should be happy and go away. But these people get very symptomatic. So I think you're absolutely spot on. And I've experienced it. It was a year before she kind of, said, okay, maybe I'll, won't disown you from my will. So it's a dangerous thing.
Thank you for sharing that. The paraffin drops would be an interesting thing for Indian farmers to pick up.
There are patients who come to say, you give me back my cataract. I was much better before that. No, what is the cause? Why it become such a blown up, and in some cases it becomes permanent, not temporary?
So it's a problem of that cycle that I showed you. So what happens is that there is tear instability. That instability is causing a lot of problems with the corneal nerves there. So the effector arm, which is ideally supposed to go back and tell your ocular functional unit that let's send in more tears, is just, it stops. So there is no dilution, there is no tears coming in. So there is again a tear hyperosmolarity and then damage. So there is never a break in that cycle. So I think that as clinicians, we can always look at it. It may be a mild dry eye, but the minute we start a lubricant or any kind of treatment, we are breaking that cycle and then restoring the normal. So I think that hyperosmolar tear, so a lot of studies are being done about tears, and they are learning about the inflammatory mediators that are in there. That's a little far short for a private practitioner like us. But if we understand that we need to break this cycle and then treat them accordingly, that's going to tremendously make a change. And we have seen this in a lot of our patients. The minute we start a lot of things regularize, we have studied their epitheliums which do get better, and definitely a better visual quality has been seen.
You mean to say we should get the tear analysis done?
No, you don't need to, sir. This is just for me to show that, yes, I clinically saw it, and then it corroborated with the scans.
Like
we can
doctor had pinpointed some drop,
Yeah,
Can we
yeah.
pinpoint something like that?
So I do like to use a lot of, the DUCE protocol for treatment like you saw, it's very exhaustive, we can follow it. But what I've also seen is that if you diagnose what type of dry eye it is, if it's a meibomian gland one, maybe a lipid supplement is something that I have seen which works very well. Not many secretagogues that I have really prescribed, but sodium hyaluronate also seems to work quite well. And cyclosporin also is a main factor in my private practice that I have given to my patients and seen the ocular surface regularized.
It's very, very frustrating. You did a beautiful phaco, nothing you see, the patient is always unhappy.